Hi everybody, thank you for joining me. My name is Dr. Bill Owens, and today I'm going to talk a little bit about the organization of your reporting. Now, I would recommend that I did an introduction on reporting as a marketing tool. I would recommend that if you haven't listened to that video yet, stop this one, pause it, and go listen to that one first, because this is almost kind of a follow-up to that, and you'll understand what I'm saying a lot better if you get the first part. So when you're looking at the format of your report, now this is an initial and an evaluation report, not a daily soap. The daily soap, we know, is a shorter note that's basically just reviewing the office encounter and outlining what's happening with the patient on a visit-to-visit process. The real decision making occurs at the initial examination and your reassessments throughout care. Now, Medicare guidelines dictate about every 30 days you need to do a reevaluation, so that's something to keep in mind, and that's really what you should target. But in an initial report, we know from a evaluation and management, E&M coding perspective, that each level of coding has a specific criteria of categories that have to be included, as well as the time that you spend with the patient. So what we're looking at is the time and items such as history of the complaint, family history, allergies, medications, work history. Those are all important, and I'm not really going to get into those. That's more of a coding discussion. But today, I wanted to talk to you about the single most important part of your report. Your note that goes out on the initial and reevaluations to the medical doctor. That area of your report is the assessment. This is the area, when I consult across the country, this is the area that gives people the biggest problem. And for some reason, it's a mental barrier as to what should go in the assessment portion of your report. The key to all of this, and what you should understand, is that your diagnosis is not your assessment. Your assessment is, if I were to come into the treatment room and saw you with that patient and I said, "Hey doc, what's going on with Susie?" you would be able to say A, B, C, and D, and you and I would have a conversation about what's really happening with her. That's what your assessment is. And when a medical professional, a family practice doctor, or a medical specialist gets your report, that's the first thing they look at, because your assessment is going to dictate whether they believe you, whether they think you're competent, and whether they're going to work with you long term. And if you don't have some verbiage in that assessment that are discussion points, you're going to lose the ability to build that relationship. So your assessment is key. And it's a small 3-4 line outline of really what's happening with the patient. You know, she was in a car accident, it's going to be a while before she gets better. This is what we're doing, this is what I expect, and if she doesn't get better, this is what we're going to do. Very simple, but I can coach you through that. This is what I do with doctors. The first thing we look at is your documentation, and I will help you to be able to improve it in a way that will help market your practice, and it will help drive patients to your office. But when you're looking at your reports outside of meeting the coding guidelines, the assessment is the #1 place that we need to focus our attention. And once you get it, that's it. It's very easy and it's very simple, but it will completely change your professional relationships in your area. So thank you very much for taking the time to listen to this. My information is below. The best way to get a hold of me is via email, and I'd be more than happy to talk to you and answer any questions that you have and help you overcome any hurdles that you're experiencing. So thank you very much, and I look forward to speaking with you.